Hello, and welcome to Explore the Neuroverse. Hello, and welcome to Explore the Neuroverse. Today we have Dr. Ashley with us, clinical psychologist. And the idea of you coming on Explore the Neuroverse is that you're going to give us somewhat more of the technical side of some of the language that we use throughout the series. Because obviously I'm not an expert, I'm a mum, I'm neurodivergent myself, and I have lots of questions that come up during the season around different language and different therapies and things like that. And it's really great that you've come into the studio today so we can sort of unpick and unpack some of the language and the therapies and sort of give our audience more of a guide of how to navigate some of these spaces. So you're a clinical psychologist here in Dubai. Could you just sort of guide the audience through some of the experiences that you've had like, where did you start here in Dubai?
Yeah.
Well, actually not in Dubai, was it? It was in Abu Dhabi.
It was in Abu Dhabi.
Yeah.
And yeah, before that, so I was in the UK and then I came to Abu Dhabi and then Dubai. So I'm a UK trained clinical psychologist and I worked in various specialist services in the NHS, so paediatrics, neuropsychology and CAMS, and then moved to Abu Dhabi and then Dubai. And since I've been out here, I've held a leadership role in a CAMS team. So CAMS is Child and Adolescent Mental Health Service.
Okay.
And now that I'm in private practice, I work with children and adults and have a particular interest in trauma and neurodiversity, so supporting individuals through assessment and therapy.
Okay. And taking sort of a step back, what was your first experience of neurodiversity?
Oh gosh, many years ago now. So my career, even before I became a psychologist, I looked after and accommodated children, so children who were in the care system and care homes in the UK. And a lot of that population actually had neurodiversity. So that was probably my first time coming across it before I became a psychologist. After becoming a psychologist, I guess pretty early on in your career, I came across neurodiversity. And often how neurodiversity presents is it'll present as something else.
Right, okay.
And a lot of... Yeah, so in a lot of the services that I worked in the UK as a psychologist, it was maybe, when I think about children specifically, it was maybe families presenting with their child struggling at school, struggling with bullying, or struggling with anxiety, or struggling with low mood. So,
or potentially behaviours as well, right?
Behavioural difficulties.
Yeah.
So that was the surface of what people were seeing. And often when you scratch the surface, actually there was undiagnosed neurodivergence, not with everyone, but with a lot of cases that were actually presenting to CAMS teams in the UK. That was what we were seeing. Okay,
so you were seeing sort of beyond the presentation, as it were, like, because people just look at what's in front of them, right? They don't necessarily think about maybe there's something else going on, which obviously I think more prevalent nowadays with children, like in schools and so on, when they are presenting in certain ways, people are now potentially looking for neurodivergency. But that wasn't the case before. Yeah,
it reminds me how long I've been doing this. So so we know a lot more now, but even when I started out, I guess what I'm trying to think, when I was really junior in my career, we were starting at that point to understand more about it. But I guess what we know now more is about things like girls and masking. And I guess the kind of people who would have been picked up earlier would have been people with really obvious traits, or your more stereotypical ADHD child, or your more stereotypical child with autism.
Yeah. The ones that it's more obvious traits, right?
Yeah. So they would be picked up early on. But for children who either, if it's ADHD and your symptoms were less severe, and on top of that, if there was masking present, it was often understandably missed because we knew less about it.
Yeah.
Or for a child with autism, if you were more what we call high functioning, so again, less difficulties.
Yeah.
Then on top of that, if you were masking, so these children kind of slipped through the net or went under the radar until
that
later
happened
on.
with my own child because Monty has a diagnosis of autism and ADHD.
Okay.
And he wasn't actually fine, despite the fact that we sort of had struggles in some way with him since he was 18 months old. He wasn't actually diagnosed properly until he was nearly 11.
Yeah.
And we went on this very strange journey because there wasn't any one like hard and fast set of characteristics to say he is this or he is that.
Yeah.
It was very hard we went to all sorts of ed psychs and whatever, and no one could really, until that, like he was 10, be like, okay, it's actually both.
Yeah.
Actually, up until that point in time, no one had mentioned autism to me. So, I mean, everybody presents differently, right? And now we have more knowledge and more understanding to be able to see the masking or some of the other traits that are not the most typical, let's say.
Yeah.
So one of the questions I got asked on a podcast recording yesterday was, what does neurodivergency actually mean?
So I guess neurodivergency or neurodivergence or neurodiversity is a term that kind of came out round about the 1990s, and it was a term that has been brought about to less focus on difficulties and deficits or disorders and have a more inclusive language, or a language that recognises it's a difference in how the brain works, and that comes with both strengths and difficulties.
Right.
So if you think about ASD, autistic spectrum disorder, or autism spectrum disorder, or ADHD, attention deficit hyperactivity disorder, it has disorder in the title.
Right, yeah.
So I guess neurodiversity helps to describe those where their brain is developing differently and processing the world around them differently. And there's both strengths and difficulties that come along with that, just like there's strengths and difficulties in a neurotypical brain.
Exactly, yeah.
Yeah.
And we talk a lot about that in different episodes, because actually those of us with these busy, creative brains, like that's part of our brilliance, because our brain works differently, and we can, for me, mine works like a puzzle. I can see sequences and patterns and I can identify that, and that helps me in huge amounts of ways, especially in my work and whatever. But there's other areas where I struggle, and that's for everybody, right? There's elements where it's strong and elements where it's where you have difficulties.
Yeah.
And actually what we talk about a lot is the fact that we need tools to help us with the areas that we struggle in.
Yeah.
And those tools can look, obviously, look like many things. So obviously right now you've got things like sensory aids or AI to help dyslexic people with writing an email or something like that.
Yeah.
But if we look at it from a clinical perspective, so what are the therapies that are available to neurodiverse people to help them with their struggles, weaknesses, whatever we want to call them?
Yeah. It's important because whilst we want to say that, it's a difference in how your brain processes information and how your brain develops, there is real impairment that comes with both that's important to be acknowledged in terms of the world we live in is not necessarily friendly to people with neurodivergent brains. It's a challenging world for them to live in. So if we think about schools, for example, if you are neurodivergent, school is a really challenging place.
Really hard.
Yeah,
really hard.
Really hard.
Yeah.
Friendships are really challenging as well, whether you have autism or ADHD or autism combined with ADHD. Peer relationships can be really difficult. So whilst, yes, it's a difference and there's strengths with it, it's also important that there's the right supports. Given that the environment can be really challenging. So in terms of therapies, it depends what the goal is and what the difficulties are.
Okay, so let's take a step back then. So you do diagnosis as well, right? But we had a conversation previously and you explained to me that it's a multidisciplinary process. Is that right?
So I guess when it comes to thinking about the support team around the child, multidisciplinary is best. So if we think about the different roles that exist in a multidisciplinary children's service, you've got occupational therapists, speech and language therapists, psychologists, psychiatrists. I hope I'm not missing anyone out. Pediatricians.
Yeah.
So it depends on the goals. So, for example, for a younger child, you will involve the parents a lot more. So, for example...
So does that, sorry to interrupt you, but does that mean that you come to yourself, the child is diagnosed with whatever the outcome is, and then do you then guide the parents through based upon what traits or presentations you've seen from that child?
Yeah.
You will formulate a therapy plan or something along those lines, based around the struggles that you've seen that child is presenting. Would that be fair?
Yeah, that's a really helpful summary, actually. Okay. That's exactly it. So the door doesn't stop at diagnosis. Diagnosis is just the start. Mm-hmm. So whenever I'm assessing a child or there's anyone assessing a child, diagnosis is just the starting point. And within any diagnostic report should be a list of recommendations for that child based on what we see the challenges they're presenting with. And each child is different. Yeah. So some children might need speech and language therapy. Some children might need an occupational therapist. Some people might need the SEND department at school. It really just depends on that child's challenges. But when the parent walks away, they shouldn't just be walking away with the diagnosis. They should be walking away with an understanding of the child's strengths. What are they struggling with and what professionals can support with those struggles? Yeah.
And I think that's really important as well for the audience to understand, because that wasn't my experience.
Okay.
I'm talking about a few years ago and, things may have changed since then.
Yeah.
But I basically left. Didn't even leave the clinic. You go for the diagnosis, and then the paperwork gets sent to you later, and you read it, and you're like, okay, so my child has this. Now what do I do?
Oh, okay, which is so hard. Yeah.
Yeah. So actually, it's really interesting to hear you say that. Actually, that it's that plan or those suggestions, recommendations, let's say. Should be within that documentation, right? So the parents should then almost have a next, what's next checklist,
it should be
right?
like a roadmap.
Right, a roadmap, exactly, yeah.
But that's really helpful you talk about your experience, because I guess I'd like to think that that's not the experience of many, but I don't know, because I don't know what all exists out there, but that might still be going on for some people. So that's really helpful you bring that up.
So that's why sort of it's important, I think, for the audience to know what they should be if they're on this journey and they haven't had a diagnosis yet, and they're sort of thinking, maybe I need to go and seek out a psychologist, a clinic, whomever, to start that journey. You often don't know as a parent the questions that you need to be asking, and it's a daunting process. And you go into this clinical environment, and it can feel quite overwhelming. And to actually know that there's certain questions like what will be given in the report will you be providing me with recommendations of therapies, recommendations of who I need to speak to in school or what happens next. I think that's actually really important, because the process itself isn't inexpensive. And so therefore parents should be able to set the expectations with the clinic at the beginning of the process, that these are my expectations. And if the clinic's doing it anyway, fantastic. But maybe not all of them are. It wasn't my experience. So therefore, perhaps that's not what everybody's getting. And so therefore, when you're spending such a lot of money, maybe contact the clinics first and find out what their protocol is, rather than just going straight to one clinic without asking any questions.
Yeah. That's so helpful to bring that up. Yeah, because we don't know what's the standard everywhere. And actually, it's about empowering families, as you say, to navigate it, because it is a difficult roadmap to navigate. There's so many different steps to, first of all, recognising there's a difference I'm noticing in my child. Then what professional do I go to about this? What's the right kind of assessment? And then what should I expect from that assessment? And where do I go next? So there's a lot to navigate there.
Absolutely, yeah. And let's also, I mean, we've been talking about children, obviously, because I focus obviously on my children, but this applies to adults as well, right?
Yeah.
Do you have a lot of adults coming to you for sort of this? I know there's lots of people of my generation, as it were, that, you know, we weren't diagnosed at school or whatever. Do you see a lot of people, adults coming to you now for that late sort of diagnosis process?
Yeah. What often happens is either the adult will present to me, the adult client, with a mental health difficulty or needing coming to therapy for a different problem. And then through that, we might uncover, undiagnosed neurodivergence. Or what happens is it's a parent who their child has been recently diagnosed and therefore they're now reflecting. Or what happens is it's a parent coming to me for their child saying, I'm wondering about this in my child. And as I'm wondering about this, I'm also wondering.
Yeah, I hear that a lot from neurodivergent parents. I mean...
And it's highly heritable. So it's often when the parents reflect upon the things they're seeing in their child and then they reflect, well, actually, I was a bit like that when I was younger. So I guess what's nice is when clients come to me, I'm able to support them through that whole process. So in terms of if it's just an initial wondering or if they've already been diagnosed and now it's what to do after, or if it's they're looking to embark on diagnosis but wondering where to go. And it's different for children versus adults. So I guess it's helpful for people to know that typically who would diagnose children with neurodevelopmental conditions like autism, ADHD, dyslexia, it would be typically people who are involved might be, for autism and ADHD specifically, pediatricians, psychiatrists, psychologists with specific training in those areas. And you should be looking for someone who's going to do a multi-informant, multi-method assessment. Okay, so that is the standard. So it wouldn't be just sitting down with the parent. So what you should expect is best practice, which is the NICE guidelines from the UK, which I operate from because I'm UK trained. So they would say it should be multi-method and multi-informant. So your person who's doing the assessment should be speaking to you. They should be observing the child. They should be speaking to school or nursery or any other professional that's involved. And they should also be using standardized tools for whether it's ADHD or autism.
Okay.
The important thing to say there is, though, there's never one single tool that's relied upon. So whoever's doing the assessment should be looking at the whole picture and formulating all the information together to see, okay, is this child presenting with enough traits that would meet the criteria for this, this, or this?
Right.
And sometimes, and I always prepare parents for the fact that the answer will either be yes, they meet the criteria, no, they don't, or it's watchful waiting. And the reason being some assessments do come back where there is traits, but it's not enough to make a diagnosis. And the difficulties might not be more evident until later on in life.
Okay.
So I say to those parents...
Watchful waiting. I've not heard that before.
Watchful waiting.
Okay.
And I say to those parents, it's never a waste when it's watchful waiting and you've had the assessment, because the reason you're coming for the assessment is you're noticing your child is struggling with something, whether it's school, friendships, or their emotions. So if it's watchful waiting, I would still put in the report what's going to help this child. While we're wondering, is this neurodivergence, but we're not sure. But in the meantime, these are the things that's going to support your child. And when it might be helpful to come back to see if actually things have got better, or if it stayed the same, or if actually there's more things coming through that are making us think even more so they're now meeting the criteria. So
okay, so in that case, do you sort of give them an idea of what they should be looking for? Yeah, okay, so as more, do traits become more prevalent as you get older, or can they?
They can. So it depends on the individual. So obviously everyone will present differently. Interestingly, what they've noticed in the research is that for ADHD, traits in girls will become more prevalent, or the impact on functioning tends to become more prevalent later in life.
Oh, that I can believe.
And they, and they don't know if that's about traits emerging in a different way or if that's about masking, but there's something about when you reach adulthood, they're having the same impact on men and women, but the impact on day-to-day functioning doesn't seem to be as much in women until later, is what the research is telling us. We don't fully understand why yet, but that's just for ADHD specific if we compare women to men. But yeah, things like what I say to everyone is, if we think about adolescence and your child going through the normal stages of life, adolescence is hard.
Oh, yeah.
So what we often see is children who have underlying neurodivergence, but it hasn't been picked up. It more likely gets picked up during adolescence because the masking and things are harder to maintain. Hormones are going on.
I was going to say, do hormones have an impact?
Yeah.
Yeah.
Just like they do on a neurotypical
Well, of course,
child.
yeah, they affect everybody, right? Yeah.
So with ADHD or autism, emotional regulation is a big part of it. So difficulties managing, regulating emotions. So then you put puberty and adolescence into the mix. And the social world becomes more complex for children during adolescence. There's more to navigate. High school is such a bigger, more complicated environment.
Yeah. So, and now, of course, you've got all this digital communication where responses are instantaneous. You know, you can have an argument with someone on a message.
Yeah.
I think if I use sort of my own experience of having a teenage child at home, you know, it's very easy to say spiteful things when you're behind a telephone rather than in front of people, which obviously I didn't have telephones when I was a kid, you know what I mean? And then, you know, everything is so instant that what I see with my son is at some points I actually have to just take the telephone away because it's like, this is actually overwhelming you and you've got sort of stuck in that cycle of comms where actually, you know, if you had an argument with your friend at school one day when we were younger, you had the evening, you processed it, maybe you talk about it, maybe you didn't, but by the time you go back the next day, you've calmed down, you've thought about it. Maybe it isn't as big a deal as you thought about before, and then you have a chance to apologize and work it out. But when everything's so instantaneous, that moment doesn't happen.
Yeah. It's when it comes to ADHD, it's about your executive function and your inability to inhibit your responses, whether that's your behaviors or your emotions. So it's like stimulus response is the easiest way to look at it.
Right.
So the older we get, there might be a stimulus, then a thought process, then a response. But ADHD, it's a bit like that pause is harder for someone with ADHD and the stimulus happens and then the response happens. And actually...
So there's no real processing in between?
Yeah.
Right.
It's a reaction. So actually that example is a really helpful example. If you had something happen at school that day, you would have time to go off and cool off. Whereas WhatsApp messages or any kind of like social media, there is the ability there to react quickly and to get yourself into more trouble or to get yourself into a more difficult situation through no fault of your own though, because that's how your brain works. You've not got that stop and pause. So that's actually a really good example for how modern day and how things are modern day compared to years ago impact someone more detrimentally if you have ADHD and you have a disagreement with your friend in the playground.
That's true. That's true. So we talked about child diagnosis, but you said actually the child diagnosis and the adult diagnosis has a different format? Yeah. So what would an adult diagnosis look like in terms of, do they have their multidisciplinary team? How does that work?
It depends. So child diagnosis, are we talking autism, ADHD, or kind of...
Well, that's the thing. Actually, let's take it back a step then. If you, like maybe as an adult, you think, okay, there's something not right with me. I don't know what it is. So one of my experiences is I have a friend who, from my layman's terms, appears to have traits of autism and ADHD, but has a diagnosis of ADHD. But when they went to seek a diagnosis and went to a psychologist, they said, I think I have ADHD. So they were only screened for ADHD rather than presenting and saying, I'm not quite sure what's going on with me. And then presumably in that case, you would be screened for any number of things. I don't know. How does that process work?
So if an adult was coming to me saying, I'm wondering about neurodivergence within me, it would be a detailed developmental history. Now, obviously, you're not going to remember past a certain point in your childhood, so there's only going to be so much you can remember. So what you would want in that instance is as much of a history from them as they can remember about friendship, school, working life, how that has been for them. And then ideally, if they have a parent or an aunt or an older family member who remembers them from when they were younger, or even if it's a sibling or a cousin, but someone else who can corroborate, how they were through the years. So you want that information. And then you might think about standardized tools. So for an adult with ADHD, we have, for example, the DIVA, which will look through certain characteristics that we know are associated with ADHD. And, so you would look at how many of those characteristics are you presenting with. But again, that's one tool, and you would take that into account with the wider assessment information. So ideally, you want someone else to corroborate your history.
Okay.
You want your own account, so having an own detailed account from the person, and you want a standardized tool to look at.
Okay, that's interesting. So I just wanted to swing back because you earlier mentioned that in one of the team, I think for the child diagnosis, there would be a psychologist and a psychiatrist. And now one of the things I've never really understood is, what is the difference between a psychologist and a psychiatrist, and what do you go to each of those professionals for?
Yeah, it is confusing, I know.
Well, I think the thing is that when you are thrown into this journey with your children or yourself or whatever, there's a lot of language that's used that you don't necessarily understand. And I think people are a lot of times sort of shy to ask those questions. So I think this is a really nice opportunity to sort of unpack some of those languages and understand what is your role as a psychologist and how does a psychiatrist complement that role, for example? Yeah,
absolutely. So a psychologist and a psychiatrist can both assess, treat and diagnose mental health difficulties and neurodevelopmental conditions. The difference is, once the diagnosis is made, a psychiatrist would support you through consultation about medications available to you if they think it's appropriate. It might be it's not appropriate, but they will make you aware of your medication options for management. They will also, or should also, be thinking about therapy, because medication should never be used in isolation. And it's always about, if medication is going to be used, therapy should also be suggested. So ideally, you would be wanting, if you went down a diagnostic route with a psychiatrist, you would be wanting them to then say, okay, and let's think about therapy, and bringing that to your awareness.
Okay.
If a patient comes to me or a client comes to me down the diagnostic route, then if it's autism, there is no medication for autism. So I wouldn't refer to a psychiatrist for medication for autism. I would only be thinking about therapeutic approaches, whether that's through speech and language, occupational therapy, or psychotherapy for either the child or the parent. If it is for ADHD, we know there's medication for ADHD. So I will always recommend a consultation with the psychiatrist if you want to explore medication. So I will never say you must, because it's down to the individual or the parent.
Course. Yeah.
But I will always say there is medication options available for ADHD. I'm not a medically trained doctor. If you want to explore that, the person to go and explore that with would be a psychiatrist. And I also recommend X, Y, and Z in terms of parenting or whatever it is.
So it works hand in hand.
Yeah.
Basically.
So whether you're being diagnosed by a psychiatrist or a psychologist, they should be making you aware of what is the helpful next step for you here. Are medications an option or not? And also what therapy options are out there for you. They should be guiding you with that.
Sure. And on that note, you mentioned just now speech therapy, speech and language, I believe you call it, occupational therapy, and there was what was the other one you said?
Psychotherapy. So psychotherapy, just what I would deliver in therapy. So psychological supports or psychological therapies.
Okay, so that could be...
It depends on the presentation, but it could be cognitive behavioural therapy,
Right.
acceptance and commitment therapy. It could be EMDR. It could be person-centred counselling just to help you with processing the diagnosis. It could be parenting work for the parent to help them understand how to support the child with the diagnosis.
So obviously there's quite a lot in there. How do you identify which one of those is suitable for a client? Do you have a session with them, and then based upon that session, you're able to sort of guide into the different types of therapy that might be suitable for them?
Yep. So we work from an evidence base. So we have what's called the matrix, which is what we refer to, and we have NICE guidelines, which is, as psychologists, what we refer to that based on what you're presenting with, this is what the evidence says is the best therapeutic approach. So I would do my assessment. I would look at what are the strengths, what are the difficulties, and based on what they're presenting with, what does the evidence say is the best therapeutic approach for this?
Okay,
so,
that makes sense.
So it's always rooted in what the evidence says.
Perfect, yeah. And you mentioned, I know you're not an occupational therapist, but for the audience, I think it's worthwhile identifying what an occupational therapist is and what they're offering.
Yeah. I hope I do it justice. And no occupational therapist is saying we do more than that. But my understanding of the occupational therapists I've worked with is when it's children, they will help them with day-to-day living tasks, but also emotional regulation. They can also support anxiety management as well. Transitions, things like that. If you move into adulthood, it would be about supporting you with work. So if you have neurodivergence, for example, ADHD, it might be advocating for you with your employer about this is how the day-to-day tasks might be made easier for this person based on their neurodivergence. So it's about advocacy and making the environment work for the individual.
Sure.
And for younger children, it might be also about equipping the parents with how they can change the home environment, how they can support with transitions, going into the school and making sure that the school environment is supportive as well.
Yeah, I mean, I've got my own experience with occupational therapy for both of my children. And actually, I think a lot of the physical movement that they do for, I think it's their 7 senses, that really benefits them in the moment. But actually, as you say, it's those, from my experience, the occupational therapist tools that they guide you through what you could benefit from having in your home, such as weighted blankets or bands on the children's legs at the dinner table, or in my son's case, the exercise ball to sort of bounce on. They can guide you through those tools that if your child is having a moment, a meltdown, dysregulation, et cetera, what are the tools that are going to help you in that moment? I think I'm going to have an episode on occupational therapy to go into that in more detail, but I just wanted to, for the audience's benefit, sort of touch on what that means. Sort of coming back to the therapies that you offer, are there different therapies that apply to different age groups? Like, would a child be offering a different type of therapy to what an adult is offered? Or do the therapies that are offered cover all of the age ranges?
Well, I guess the younger the child, the more you're involving the parent in the intervention. So, for example, for a 3, 4, 5-year-old, I would be working with the parent. And it might be that speech and language or occupational therapy are involved with, like, things like you said, like pragmatic things. But for example, psychological therapy is talking therapy. So I wouldn't be talking to a child.
Of course,
Usually I would see 8, 9, 10 and up. Younger than that, you would be looking at play therapy, which I don't do, but there's lots of play therapists out there. Younger than that, I would predominantly be working with the parent about supporting the parent about, okay, if they're struggling with emotions or social relationships, how can you support them? Or you would be looking for a play therapist to work directly with the child, because at that age, they are exploring the world through play.
Of course, that makes total sense. So from your perspective, people would benefit from the therapies that you offer above 10, above 12? What's the sort of...
So I
guess person dependent, of course.
So EMDR, you can do I do EMDR with children and adults. Cognitive behavioural therapy I do with children and adults. And then there's the third waves, acceptance and commitment therapy. So yeah, I tend to predominantly work 10 and up. But if I have someone contact me and say my child's 8 or my child's 9 and this is what they're struggling with and I know I can help, then I will support a younger child. But if I think that child is better going to someone else like a play therapist, then I will suggest that.
Sure. Now, EMDR, I only heard about very recently when we met. And I feel like since I met you, I've heard it like 4 times in different conversations. It's weird how that happens, right? Yeah. And I'm not even talking about the algorithm, literally in actual conversations with people. So for the audience, would you mind explaining what EMDR is?
Yeah. So EMDR is eye movement desensitization and reprocessing. It is a trauma-based approach and it works on the adaptive information processing model where it helps to shift traumatic memories to the correct side of the brain so that they're less impactful on you. So I talk to people about it's best to view it as like a filing cabinet. So your brain puts things in different filing cabinets. Traumatic memories tend to get stored in the wrong filing cabinet. EMDR helps to put it in the right filing cabinet so that it's no longer impacting you or as distressing in the present moment. So you still remember it, but the distress is reduced because it's been filed away properly.
Okay. That presumably there's research to back up that, what does the research say about the outcomes?
So EMDR, the initial research studies were on PTSD and war veterans. So it is in the NICE guidelines, it is in the matrix as an evidence-based therapy for trauma. So it is recommended. What I always say to people though is the evidence basis for trauma, and people think about single events trauma, but EMDR is more and more getting used for so many different presentations, and there's more evidence coming out, more research coming out to show how effective it is. So when we think about trauma, we often think about single event traumas like a traffic accident or a significantly traumatic bereavement or an attack. But actually what we know is the general population have experienced what we refer to as small T traumas, but a build-up of them. Small T traumas might be things like receiving a critical comment from a teacher or being rejected by your peer group at school or being embarrassed one day in class when you were asked to answer a question and you didn't know the answer. All of these small T's, when they accumulate, can have a massive effect on our view of ourselves, and we can hold those emotional wounds.
I mean, you can correct me in this process, but my understanding of a lot of neurodivergence, specifically ADHD, is that RSD is a massive part of it. My husband has it; it's huge.
Yeah.
I was just been talking about it with Sarah from Three Busy Brains as well.
Yeah.
That she calls it the negative bird that lives in her mind and just tells her she can't do anything, basically.
Yeah.
But it is very real, RSD.
Yeah.
And is that something that EMDR would help with?
Yeah. Well, when we think about children with ADHD, I think the stats say that by a certain age of adolescence, they've experienced 20,000 more critical negative comments.
Correct. Yeah, I've seen that.
Yeah, neurotypical child. So absolutely, if we think of the build-up of those small T's in someone with ADHD, huge impact on self-esteem and confidence. So actually, EMDR can really help with those experiences. And what we know is that those experiences can lead to quite unhelpful beliefs about ourselves, whether it's not being good enough. And what EMDR can help to do is process those difficult memories. So you still remember them, but there's adaptive processing that happens during the process of EMDR. So what by the end of it you'd want is the difficult events to be processed and also a more adaptive belief like I am good enough.
Yeah.
Or I am a superstar. So by the end of EMDR, you want someone who's holding these difficult beliefs about themselves because of these difficult moments they've experienced in life. And by the end of it, you want them to have a more adaptive or positive belief about themselves. And whenever I've done EMDR with anyone, the results are just amazing.
Amazing. Yeah. I'm fascinated by it.
Yeah.
And how, like, what does a course of EMDR look like? Is it a number of sessions, or is it based upon the feedback? Like, how does that work?
Yeah. So if we are thinking about someone with a single event trauma, like a car crash, then that is going to take less sessions than someone with complex PTSD. Complex PTSD being there's been trauma over a period of time and more significant trauma. So the more trauma that's there, the more sessions are needed. And we don't really have a specific amount, but what I can say is typically EMDR takes less sessions than, for example, other trauma-based therapies such as CBT for trauma. So we can't say, yes, you're presenting with this, it's going to be this amount of sessions, but typically EMDR gets quicker results.
Okay, so those results become evident quite quickly.
Yeah. Sometimes after one session.
Seriously?
Yeah.
Okay.
Yeah. So it depends on the client. So if I'm working with a client and, for example, there's a more significant history of trauma there, we might spend more time in the kind of safety and stabilization stage where we're doing relaxation strategies and we're doing kind of getting them ready for the reprocessing. So we call it resource work. So that there might be a period of time for that, but there's a lot of clients where once we've got on to the EMDR and the reprocessing of the difficult event, sometimes by the end of the first session, the distress has come down. So at the start of each session, you would rate their SUDs, so their subjective units of distress at the start of the session. So that gives you as a clinician as an idea of has their distress stayed the same or shifted.
Okay.
And sometimes by the end of one session it's shifted. Not always, but sometimes it has.
Fascinating. Yeah. I mentioned RSD before, which is rejection sensitivity disorder. Yeah. Is that an actual diagnosis or is it a term that is used?
It's a term that's used. So it's not recognised in the DSM. So it's not recognised as a psychiatric condition. But we know it's very real.
Yeah. Oh, definitely.
Yeah. So we know it's really real, and it's just been a helpful phrase that's been coined in the community to, I guess, give a label or a language to it.
Yeah. And help people to understand, right? Because that's we sort of unpack this use of the word label a lot during the series. Mainly because, like, when I was younger, for example, of that generation, having a label was seen as a bad thing.
Yeah.
And obviously the narrative and the understanding is sort of changing in terms of it's not having a label, it's having your child or yourself correctly diagnosed so that you can then seek the help or tools or therapies or assistance that you need to be able to function more successfully. Not that you're not successful already, but you can be more successful with more tools.
Yeah.
So whilst the labels have a negative or within society have this sort of negative connotation, actually having a diagnosis is sort of the opportunity to provide yourself with more information and understand yourself on a deeper level so that you can be more successful.
Yeah, absolutely. And it's often when I have parents come to me, one of the questions they'll say to me is, I don't know if it's helpful to go down the assessment route because I don't know if I want my child labelled. And I will always give parents as much information as possible so that they feel equipped to make their own decision, because there is no right or wrong decision. It's what's right for you as a family.
Right. Yeah.
But what I will say to them is, in my experience, children where there is underlying neurodivergence, because it has such an impact on day-to-day life, what can happen is they're mislabeled and they're given the wrong label. And then they're not supported in the right way and they're misunderstood. So often having the right understanding leads to better support earlier on, which leads to better outcomes. So I often say it's about having the right label rather than your child being mislabeled.
Yeah, I agree with you. Yeah. All right. Well, thank you very much for coming in and discussing. I mean, I hope that in the future you're going to come in again. Yeah. And I sort of, what I'd like to do is sort of invite the audience to sort of send in to me on Explore the Neuroverse any questions that they have or topics that they would like us to unpack with with the use of your expertise. But in the meantime, how can the audience reach out to you if they're interested in any of the therapies that you've discussed today, or just reaching out to you to perhaps ask questions, where can they find you?
Yeah, so currently I'm based at Genesis Healthcare in Science Park in Dubai, but I'm also on Instagram at Dr Ashley 19.
Fantastic. All right. Well, thanks very much. And we hope to see you again.
Yeah, thank you for having me.
Pleasure.